Thank you, everyone, for joining us. Right now, I have the pleasure of introducing Dr. Richard Pither. He's the CEO of Cytox Limited. And today, he's going to be talking about the identification of patients at highest risk for cognitive decline due to Alzheimer's disease from simple saliva samples and actions to take to delay the onset of symptoms. Richard?
Thanks, Nikki, and thanks also to Lavinia for the invitation to speak today. It's a pleasure to join everyone. My job specifically is to talk about Genoscore, which is a type of polygenic risk score test that we've developed in partnership with scientists in the UK at Cardiff University and UCL, and how we've employed that basic science in the form of a product that's now rolled out just recently in the US and Canada, and also in Europe and the UK. Of course, everyone knows there are a huge number of people, estimated around 46 million globally today, that have been diagnosed with Alzheimer's disease, and that will double by the end of the decade. What people, or fewer people, understand perhaps is that lifestyle interventions and behavioral changes can play a significant role in maintaining cognition and function and preventing dementia, or at least slowing down the decline, even in people with early symptoms. And I think this is really important work that was summarized by the Lancet Commission study at the end of last year, which still has to get out much more widely than it has so far, because that's the reason, of course, why people should want to understand whether they are at future risk of developing the disease, in order to proactively take some of those steps and adopt the healthy lifestyle measures that will ultimately reduce the overall risk. And I want to talk a bit about polygenic risk scores and how they can help in that. But a reminder first of some of the factors that we've already heard mentioned in a couple of the earlier talks today about some of those factors that are listed on the left-hand side of this diagram. Some of them comorbidities, such as type 2 diabetes and hypertension. Others more to do with lifestyle and risk avoidance, perhaps in the case of hearing loss, smoking, depression, physical and social activity. We know these things can all have a major impact on our future trajectory, even if we do inherit some level of risk for developing Alzheimer's disease in the future. And as I said, this work was summarized in the Lancet Commission, which I've referenced at the bottom of this slide. And much of that work, of course, in the Lancet Commission emanates from Mia Kiffer-Pelto and her very important work over the last few years with the various finger study projects that have been published and discussed widely now, which have identified prospectively many of those things that can have an ultimate impact and benefit to patients. Of course, the other thing on the horizon now is disease-modifying drugs, the first of which, in the form of Aduhelm, was approved in June of this year by the FDA, formerly known as aducanumab, but we know there are a pipeline of other disease-modifying drugs coming through as well. So again, another reason why people need to understand whether they're on the risk trajectory or not. And although you cannot change genetics, you can change those other things. And if you do so in a timely fashion, the evidence now is that you can push that curve, that dementia deterioration curve, over to the right-hand side, delaying or perhaps reducing the slope of decline by taking these steps at the right time. So how can we measure genetic risk? The first point to make, I think, is that Alzheimer's disease has an undisputed genetic basis. On the left-hand side of this page, we can see the two forms of Alzheimer's. The very rare early onset form linked to dominant mutations in one of three genes, amyloid precursor protein, presenilins 1 and 2. And much of that was elucidated more than 25 years ago now by the work of John Hardy and others, who identified these causative mutations which result in very early onset disease, but in a very small number of people. Less than 2% of Alzheimer's globally is associated with early onset forms. The more common late onset forms has much more complex genetics. We all know about the ApoE4 associated risk, which we'll talk about more in a moment. But if we look on the right-hand side of this graphic, we can see that although ApoE4 on chromosome 19 stands out as a a very dominant risk-associated factor, there are many other SNPs and gene variants which have been linked to either increased risk or actually in some cases decreased risk of Alzheimer's disease, the ApoE2 allelic form being an example of that. So the question is, how do we look in a single test at all this genetic variance that could contribute to future risk of Alzheimer's disease? And the answer to that is that we use something called a polygenic risk score approach. So a polygenic risk score is a single number which takes into account all the risk associated and decreased risk associated SNPs or single nucleotide polymorphisms, genetic variants that one is inherited throughout the genome, and combines those in a weighted algorithm to generate a single number, which then allows us to place patients into this high, medium, or low risk category based on their genetic inheritance. That algorithm has been trained in very large data sets, in this case using the International Genomics of Alzheimer Program data set. That was about 17,000 clinical cases and about 37,000 age-matched controls to initially train the algorithm, and the algorithm has subsequently been validated in independent data sets. And I'm going to show you some of the work that we've done to validate performance in the next couple of slides. Before I do that, this is just a workflow of how our test that we call Genoscore actually works. So on the left-hand side of this graphic, we start with a saliva sample or indeed a blood sample if that has already been generated. And we can send out kits to physicians to then either administer saliva collection themselves in the clinic, or indeed this is very simply managed by the patients themselves and can be sent as a kit to the patient in their own home and then posted back to a central reference lab where the DNA is isolated and run on a proprietary genotyping array made for us on a bespoke basis by Thermo Fisher. This array contains assays for 500,000 different DNA variants, and we run 96 samples in parallel on this Thermo Fisher equipment called the Gene Titan. And this process is carried out in one of two reference labs, one in New Jersey in the United States and one in Manchester in the UK, serving respectively the United States and Canada and the European and UK clinical markets. The data from that step essentially is 500,000 binary data points, which are sent up into a secure cloud-based server where our polygenic risk score software that we call SNPfitter sits and runs the analysis and sends a report back to the clinician who's ordered the test. So some data showing the validation of this type of test. So we've worked a lot in the ADNI cohort from Mike Weiner at UC San Francisco. We did some initial cross-sectional studies to show that our polygenic risk score could differentiate Alzheimer cases from age-matched controls. And this data was published last year in the Journal Prevention of Alzheimer's Disease. But most importantly, what we've shown in longitudinal studies is the ability to identify those at greatest risk of progression. So on the right-hand side here, we've got individuals who came into the ADNI study with a diagnosis of mild cognitive impairment. We tested all those subjects. This was several hundred subjects, and we grouped them into high Genoscore result and low Genoscore result, and we followed them for 4 years. You can see that those with a high Genoscore all got worse, all progressed using this CDR sum of box clinical composite score, whereas those in the lower Genoscore category remained cognitively stable over that 4-year period. That decline cognitively correlates very closely with underlying biomarkers in the cerebrospinal fluid. So you can see on the left-hand side here, this is a simple heat map showing polygenic risk score on the right, on the x-axis, and on the y-axis, the phospho-tau 142 amyloid ratio, which is a gold standard marker of progression based on CSF proteomics. And what we can see is the Alzheimer cases here in dark blue are all high polygenic risk and high tau amyloid. Age-matched controls, on the other hand, have low polygenic risk and are below the amyloid tau ratio positive threshold. Late MCI in purple look very much like clinical Alzheimer's disease for the most part, and early MCI are a mix, as we would expect. Interestingly, if you look at the population from that previous study who actually progressed in terms of cognitive decline, they all sit in this window here, which is high polygenic risk and a high tau amyloid threshold in the CSF. So basically, by using genetics, we can get very similar predictive power to looking at more complex CSF sampling and quantitation of tau and amyloid fragments. This is not just an ApoE phenomenon. We know that about 25% of the Caucasian population carry one or more copies of E4, and yet we know that not every one of those individuals will go on to develop Alzheimer's disease. Conversely, we know that about 60% of the Caucasian population are E3 homozygotes and don't carry E4 at all. And yet, if we look at Alzheimer cases, we know about 40% of them come from this non-E4 carrier group. So how do we differentiate for risk amongst E4 carriers and non-carriers? So we've done some distribution analysis on the right-hand side here, and we can see that the E4 homozygotes are very high-risk polygenic score, as we would expect. Amongst the E4 heterozygotes, though, we see very high risk and much more modest risk individuals here in yellow. And very importantly, in the blue segment here, so these are the E3 homozygotes, we can see very high risk polygenic risk score individuals, despite the fact they don't carry E4, and very much lower risk ones as well, which correlates very well with our clinical experience that amongst the E3 homozygotes, there will be those at risk of progression. We can see that again here in some data that we've generated just recently using looking at now cognitively normal individuals and their PAC scores. So this is a very sensitive measure that can be used before people meet an MCI threshold. So we've divided here individuals into the non-E4 carriers on the left, the E3 homozygotes, the E4 heterozygotes on the right, and we can see for the first, and then we've done polygenic risk analysis. The blue individuals had a low risk and they've remained stable over this 5-year period. The red individuals have a high risk, and we can see that from 3 years out, they begin to decline using this PAC composite score. Similar trajectory in the E4 carriers. Low polygenic risk score individuals in blues remain stable. From 3 years out, we can see that the high risk E4 carriers begin to decline. So even in pre-symptomatic individuals, we can see this differentiation. So we've now launched this. It's available in the US and in Europe. It's available only through physicians, not directly to patients, and we send a comprehensive report to physicians. And that's really important that this information is relayed through that route, because it's been shown comprehensively that in order to effect behavioral change, this information needs to be handled by a clinical professional in conjunction with the patient.
Richard, I apologize to interrupt. We just have a few more seconds.
Yep, and I was just going to finish to say that if anyone's interested in learning more about this test, please look at the link here, www.genoscore-lab.com/register, and we'd be more than happy to talk through the way the test works and how you can access it. Thank you very much.
Thank you so much, Richard. I think we'll take questions for Richard at the conclusion of session 1. So if anyone has questions, please hold those and we'll get ready to start the next session. Thank you again.